Well, today I am honored to have, well, I don't know, Rich, if you were a rock star, I don't know if you'd be Bob Dylan, but maybe at least Rod Stewart, something in there. Maybe Benno would be Dylan and you'd be Mick Jagger or Rod Stewart. So welcome. Really a pleasure to have you. You've got a great book that I've had a chance to review. It's called Practical Biomechanics for the Podiatrist. And I'm going to have you in your words give you a chance to kind of explain what your rationale for the book was, and then also some of the structure of the book so that someone can refer to it. And I must say, it's kind of like a golden book, a gold key book. It's one of the most approachable texts that I've read. You can really sit down and absorb it. Now you're doing instruction now at Sam Merritt College, and you're able to review this book with your students and do some orthotic one-on-one. Tell me a little bit about the inspiration for the book, and welcome.
Well, thank you so much, Ben, and I'm humbled by your words. Yeah, I've taught for 42 years at some point every year at the California College of Podiatric Medicine, which is now the California School of Podiatric Medicine. Right now, I'm teaching second-year students biomechanics, and I have them a couple of Friday afternoons a month, and we get to explore gait evaluation and measurements and in their biomechanics workshop. They're really my muse for writing this. It's sort of, my practice has always been sort of a combination of podiatry and physical therapy, and I work in a multidisciplinary practice with the MDs and dance medicine, physical therapists. So I'm learning from everybody, and I think that's the approach that I like to teach. Like there's no one way, there's a lot of ways. You just want to, as you evaluate patients, I always tell my patients that from the day I see them, they should get better, and so if not, we go to plan B and we go to plan C. We refer for different opinions. My approach with my patients is very sports medicine-like, meaning that it's the basic principle of sports medicine was that the patient was on par, was on the same level as the doctor, which is different than the doctor telling the patient what to do, and the patient had no real say in it. So it's a very very open exchange with my patients. I learn just as much from my patients than I have from going to lectures, and because patients will come in and say, well, this is the best shoe for my foot, and this is why, and so they're motivated by that. So basically, I try to teach that philosophy that every theory out there has valid, and there's pros and cons with it, and you just have to.
Yes. And I wanted to interject, I just did an op-ed for Lower Extremity Review about teaching biomechanics, learning biomechanics. And like you say, and I'm going to have you sort of talk about some of the structure points, because even though there's 9 ways to skin a cat, you still have some good structure points that are in there as a skeleton, to decision tree off of. We get caught up a lot the term evidence-based medicine these days, but I believe there is information to be learned from a case series or even a handful of cases. As you say, we learn from our patients sometimes. We learn from our own trial and error, just doing something that maybe you didn't think of or they bring in a shoe that has a shank and you realize that you got to somehow compensate for the orthotic with the shank of the shoe because it's the marriage of the shoe and the orthotic. So one of the key points you mentioned in the book is sort of an approach to solving a problem going from the clinical. And a lot of books will go the opposite. They'll start with kind of crunching numbers and boom, boom, like a computer thing. This is your solution, 7 degrees. Talk a little bit about that approach. And then you have a couple sort of rule of thumbs that you mentioned in the book.
Well, I think you're talking about the 14-step approach I have in chapter.
Yeah, I mean, you can mention that. There's several structure points that you have in the book.
Yeah, so the way the book is outlined is, or the table of contents is that, initially it's like the general rules that I use in my biomechanics practice.
Can you give an example of one of those as we're on that?
General rules is always ice for 96 hours after an acute injury. Not 96 days, but 96 hours. Never stretch through pain. Try to add 10% when you're rehabbing a patient in the return to activity program. There's basic rules that I think we all develop in practice, but sometimes we forget to write down, and we break those rules all the time. So part of the book is to say, hey, validate what are things that are true to your practice that you have found that you can work. I call them my golden rules.
Would your return to sports be one of your golden rules? You have a segment where you said, as I read it, that if the pain scale on a 10-point visual analog scale is between 0 and 2, it is okay to proceed with your activity. That was one of the things that you had in your book.
Yes.
Would that be one of your golden rules?
That's sort of the essence of my practice, is trying, when you have patients come in with acute problems, of course, you want to drive that pain level down as fast as you can, and whatever it takes to, whether they need crutches or cast, off waiting, surgery, whatever you need to get their pain down over the first month to 0 to 2 with an acute injury. With a chronic injury, it's a lot funner, because chronic overuse injuries, people come in, they can walk fine, they just can't run 5 miles, or it starts to hurt. And so that's the fun of it. And that's how if I keep my patients true to 0 to 2, meaning they're still smiling, and I try to teach them about good pain and bad pain. Pain that comes on during a run is never good. Pain at the beginning of a run is okay, but you want it to disappear. But things like that, and so I try to. That's how I experiment with patients in changing their shoes, changing their orthotics, changing their stretching technique, changing the terrain. I'm always trying to figure out, how can I get them to work out the most, but keep the pain between 0 and 2? And whether they need to go to physical therapy to do that, or get custom orthotics if they're in over-the-counter orthotics, whatever. It helps you really get into their treatment on a visit-by-visit basis. It's a fun way of practicing.
One of the things I liked about your book too is, although you lay out some parameters for advancing to activity, you also mentioned some very specific things, and you group them under the principle of Occam's razor. And I'll give you a couple examples that are in your book, and maybe you can tell me where you sort of started thinking about this to put these very specific things in a book. For instance, sesamoiditis needs to be treated with off-weighted padding. Posterior tib tendonitis needs to be treated with arch support. And then Morton's neuroma needs to be treated with wide shoes. So what I kind of liked about that is, from your years of experience, you've given, one pretty solid thing you could start with, for the novice practitioner, which is, a lot of people. And then even for the seasoned practitioner, maybe if they hadn't thought of one of these things, in terms of depending on their discipline, you have it labeled specifically for podiatrists, but this could also, I could see a layperson looking, a runner, as in the old Jim Fix days, when people would look at the running texts and learn their medicine from that. What sort of cued you into that sort of approach, with kind of picking one biggie that maybe we start with?
Well, with Occam's razors basically is the law of parsimony. I'm not saying that right. The law of economics. It's like the simplest answer a lot of the times is the correct answer. It's the most. It's the one that that shouldn't be ignored. So it's sort of a good starting point. That, hey, we all know that for if a patient comes in with Achilles tendonitis, most likely they have tight Achilles tendons. They're general rules that tend to work. However, there are only general rules that have tons of exceptions. And but it's something that we all have these rules with. We know our neuroma patients have to wear wider shoes. Definitely until we take out the neuroma or we do our alcohol shots or whatever. It's a definitely easy starting point at the first visit. And I find with podiatry, the more treatment you can at that first visit, you've won the patient over, and you've started a process of looking for causes that really will keep that athlete exercising for the rest of their life. Unfortunately, the average runner only makes 1 year from start to finish. They start running, they get an injury, they give up on their running. And I like to say that most of my runners, we can find out why they can't run, and we can look for their all the things that can help them to run and get them to run for 20, 30 years. Now that I've been practiced for 40 years, I have patients coming back that I treated 40 years ago and are still running. Maybe their knees are not very good anymore, but so anyway, I know I'm going around and around a little bit, but
well, I have a question to ask about today's podiatrist, not necessarily the new practitioner, but maybe the new practitioner. We have a lot of seminars around the country, surgical seminars, interesting technique seminars, technological advanced seminars. I see sometimes, and I'm going to put you on the spot, do you think that in some instances with some of these technological advances that we have bypassed some of the tenets of your suggestions of Occam's razor? I know that when I was in clinic and I had Dr. Scott Millay, and he did buckets of surgery, he would, before he did any heel spur case, usually, unless there was some reason otherwise, put them in a cast for a month. Now, I see a lot of new techniques that are interesting to me. I haven't I've had the chance to follow some that have come into my office with residual pain, but I'm sure there's some that I don't see that have had great results, where there's interesting cases where they drill out the cortical bone, put that slurry into the bone. What is your feeling on, is that being rushed to that procedure a little bit more from what you have seen in the community. And I don't know how much you're tapped into what the community is doing these days, but what's your thought on that?
Well, yeah, I am and I'm not. You know, sometimes we just see what we're doing, but I do have, you know,
Do you have an
some.
opinion on that though?
Yeah, my opinion is that we're very procedure orientated, and some of the basic principles are being ignored. So like trying to get like, okay, when, if we take stem cells, like when trying to get information on when do we put stem cells into a treatment program? When do what steps do the patient have to fail so they need to go to stem cells or PRP or shockwave or just any of the the more um, modern, I should say, ones that I wasn't trained with. Um, I give the example in the book of a patient who was running, probably partially tore her Achilles tendon, partially, so she came up lame on a run. She goes to the major university in our area in the South Bay. I won't mention names. And they say, oh, you've probably partially torn your Achilles tendon. So we've got this great new thing to help you. It's called stem cells. So we're going to take a little fat from your stomach. We're gonna we're going to go do something to it, and then we're going to inject it into your Achilles tendon. It's going to probably take 3. So she goes in and she gets injection number 1. A month later, injection number 2. A month later, injection number 3. And then a month later, so 4 months into the injury, she's not any better. She's spent $1,500 a pop for the injections. And I had treated her dad years before. So she comes up to me and says, hey, I want to know what to do. I'm not getting better with these stem cell injections. And I said, okay, well, let me look at the MRI and see what's going on. She goes, oh, we haven't done an MRI. And I go, how can you do a stem cell study if you're not following on MRI? But I say, okay, well, how long were you in the removable boot or cam walker? And no, I wasn't. All they did was stem cell injections. And I go, really? So
Any heel lifts? Any heel lifts?
no heel lifts,
they
no
did?
nothing. So
Yeah.
she was completely healed in 3 months. I had to put her in a walker,
Uh-huh.
a walking cast. 3 months, and then we sent her to physical therapy.
Maybe it was a delayed effect of the stem cells, Rich.
Well,
You never know.
I told her that. I said, we'll never know what the stem cells did.
Yeah.
But it's like, I would have been even happy if they had done it, but put her in a boot at the same time, and still treated it traditionally and
Yeah.
not just. So it's just, that's part of the part that that medicine's missing right now is there's a little loss of logic. I mean, when I
You
went
think your students are starry-eyed, Rich, when they come into clinic? I mean, you're doing a lot of first and second, so you're not seeing them through the surgical rotations at that point. But do you think that the students at Sam Merritt are getting the starry eyes with the surgical procedures and thinking that that is going to be the lion's share of what they're going to be doing as a podiatric specialist when they get out?
that's my gut belief. We just hired a Samuel Merritt grad 2 years ago who only worked with us for 9 months, and then she left because our practice, she was taking Dr. Balmassi's physician who in the last 6 years of his practice was all conservative medicine. And so she took over his practice. And after 9 months, she left because there wasn't enough surgery there. She did a couple of Achilles tendon repairs for me, and worked out of the hospital, but it wasn't enough for who she thought, she should, what she should be doing. So it's too conservative. But in sports medicine, 90, unless you're at a high, unless you have all these people referring you, 98% of it's conservative, and 2% is surgical. So you don't do a lot of surgery in sports medicine unless you build a reputation, and it takes you 15, 20 years, and you build up it. You're the guy to or gal to go see if you have this wrong with you.
Yeah, you're the guy who's like some of the football orthopedists, that you're the guy who's repairing RG3's ACL.
Yeah.
Yeah.
Or Steph Curry's ankle out here.
Yeah. Yeah. Now, as far as gait evaluation, that's one of the other strong components in book one. And I didn't mention, this is going to be a 4-book series, which I think is cool. You'll have some chronology there. We talked in a pre-interview a little bit about a couple things that I thought were good re-emphasis points. You mentioned how these things can affect gait. How does like a hand dominance affect right foot pain? Give me an example of that, and then I'll let you sort of expand on a couple things that you think are missed today with gait evaluation.
Well, in terms of hand dominance, that's something that is real interesting. So when people walk, if you're right-handed, your right foot should be looser and your left foot should be stiffer. It's your support leg. So you develop the muscles for support more than the muscles for motion. And so typically when I watch somebody walk, I'll see one foot pronating or just wobbling more than the other foot that looks a little bit more solid against the ground. It could be more pronated and solid, but it's more solid. And when it's the opposite of right-handed, when it's the right foot that's solid and the left foot is loosey-goosey, I mean, that I would typically ask the patient right off the bat, are you left-handed? And they'll say, how did you know that? You haven't seen me right. So that's just one component. Now, there's so many things that affect that.
You mentioned too that you can be tricked by the muscle development and the curve in the shoulder. If you're just looking at the shoulder and not looking how the fingertips come down at the waist for right and right hand, both dominance and projecting forward or more towards the floor.
Yeah. So chapter 3 for everyone is the complete gait evaluation, which starts at your head and goes all the way down to your feet. And it's the number one thing that I've taught at the podiatry school forever, because I'm the one who teaches it. They all know that I know that world, and I get the most. If I could do nothing with the patient other than I do one thing, I would do gait evaluation outside of everything. So I work. It's about 70 pages, I think, of the book, maybe less, but it works down and it talks about what does it mean if your head is tilted or your shoulder is rounded. So there's 2 reasons as we work our way down that the shoulder may look dropped on one side. Why it's important for podiatrists is that it's a sign. It's one of the signs of leg length discrepancy, having one arm that's lower as part of our leg length evaluation. And that's something podiatrists can treat really well. So when you see in a right-handed person, if you see the right shoulder that looks low and you're not sure if it's low or just rounded because of the musculature, you then look at the fingertips as it passes the leg from right to left. And in a true right shoulder drop, the right fingertip should be lower on that side. So that's sort of how you differentiate between just a rounded shoulder and a true shoulder drop.
The other thing I liked is how you connected some of the typical patterns. For instance, if you said, if we see, for instance, the right hip seems to be dropped, and you, I think, tied that into the lumbar spine and pelvis shifting to that side, you would typically expect the curve in the spine, it would first be, you would be dropped towards, let's say, the right side, but then the curve in the spine would go back to the other side. And then because it's an S curve, typically, you would then have the right shoulder drop and right head tilt to that side that is longer. So I guess the only side, if I got this right, would be the thoracic, where the spine would be going to the left side. I know that doesn't always happen, but how frequently would you say that typically follows that that compensation pattern?
In adults, then it's about 80% of the time. So kids that are growing, it's about 50-50, because in fact, if you follow kids and short legs, and nobody really treats children at too young with short legs, but some do. Sometimes the right looks a little longer, and then 2 years later, when they come in to check their orthotics, the left side looks longer, and then 2 years later, the right side looks a little longer. You don't know how they're gonna grow, but our legs grow asymmetrically. But as adults, we tend to have the side that's higher. So if we have a long left leg, let's say, then it's going to be it's that shoulder, the left shoulder, that drops down, and then our head's got to tilt level, so our head tilts back to the right. So the head tilt, if it's a normal pattern, is towards the short side. So
I want to sort of leave our viewers with kind of the two things that you would say you really want them to get out of segment one. What you've mentioned a lot of them, but are there any other things that you would really like to have the viewer sort of glom onto from segment one?
Well, I think with segment one, yes, it's starting with when you see a patient, take a good history, watch that person walk, and that's going to open up gait evaluation is being lost in that area. It's amazing how many people I see that have 4 years of history of a problem and no one's ever watched them walk. Podiatrists tend to watch them walk, but I think that's
not always. Sometimes you'll just see them stand up and it's just that robot stance, just a snapshot.
Right.
Not the movie.
Yeah, so have them walk down the hall 5 times and get a feel of their motion. And there's all these apps now that you can even start using to start measuring angles and stuff. But that's one thing.
Do you have any favorite apps that you use for video, or do you just do a standard iPad video and slow-mo it?
Yeah, that's all I use.
I think you can get a lot of information out of that.
That's correct. That's
Yeah.
correct.
Well,
And then the end of the book, has the top 7 biomechanical examinations. So that's all going to, book 2 is going to have the complete examination, but book 1 goes through, the sort of the top ones that I use on a day-to-day basis. So that helps. And I think the last, the other one big point we haven't touched on is next to Occam's razor, which is the simplest thing, is the rule of 3, which is in chapter 2. And the rule of 3 is so important, and I find so many missing clues to a patient's injury. I'm looking for, like, if somebody pronates, they can get about 30 different pain syndromes. Their knees can hurt, their hips can hurt, their back can hurt. They can get plantar fasciitis, posterior tib, Achilles. You can blame a ton of things on pronation, and I look at that as one. So, but why does somebody who pronates, one person has shin splints, the next person has Achilles, the next person has plantar fasciitis. So then you got to look at 2 and 3, and that's why I call it my rule of 3. And always look a little deeper. Shin splints is a great example. I had this guy who, UCSF. I wasn't supposed to mention names, but major university, worked up for 2 years with his shin pain, couldn't help him. He comes in. I said he doesn't have his records after 2 years, but I say, okay, shin pain is bone pain. You pronate. I actually had good orthotics from UCSF, and I'm pushing on his bone, and his medial shin was killing him. I said, well, have you ever had a bone density test? And he goes, yes, one time I had a bone density test, and it was low. And I said, did anything happen to that? She goes, yeah, I think I take 400 units a day of vitamin D. And so I had him get a bone density test. And at the age of 27, he had the bones of an 83-year-old. And it took him 5 years with an endocrinologist to get his bone density more normal, with an osteoporosis guy. But this is somebody who I was his 12th opinion, and it was simple mechanics. Okay, is it the muscle that hurts? Is it you get the muscle strong? Is it the pronation that's causing the pain? You correct the pronation. Okay, what about the bone? Is it a bone problem?
So you hit your top 3, and then you got into metabolic information with the bone, which was good. So did they end up doing what kind of therapy? Do you remember what they ended up doing in the end?
No, he was on a lot of
hormone medication, perhaps. Yeah. Well, I'm gonna end it with this. We're coming to the end of the segment, and then we're gonna get some a bonus round in a minute. But tell me, what do? You look great. You look like you're, how old are you now, Rich?
68.
68 going on 42.
Thank you. I like
good for you. I guess you're right. What is your exercise of choice these days? What are you doing?
Yeah, so I played basketball to 64, and then my aortic valve wouldn't let me keep my heart rate down, for fear of a heart attack. So yeah, I'm a walker now. My wife and I do these 500, 600-mile walks. We haven't done it since the pandemic, but I try to walk, right, 5 miles a day, 10,000 steps, and then have a 10-mile walk on the weekend. And that's sort of my Wheaties.
Well, very good. Thank you so much for doing this tonight. And I look forward. I'm going to put you on the hook for doing another interview when you do book 2. All right. All right. Thanks, Rich.
Bye.
Bye.